Hello, thank you for the opportunity to share with you our data on an ultra-sensitive immunoassay for quantifying BDNF levels in CSF in early Huntington disease. This is a longitudinal pre-cell biomarker study. Huntington's disease is an autosomal dominant and fatal neurodegenerative disorder. The genetic mutation occurs in chromosome 4, occurs in protein Huntingtin, which is important for cell survival. It results in a mutant Huntingtin protein that has 3 nucleotide CAG repeats above 37 copies, and it's causing, therefore, central nervous system degeneration. The progression of the disease is also affected by epigenetic and environmental factors. Some clinical characteristics include progressive motor dysfunction, chorea, in most HD subjects, cognitive and psychiatric decline, weight loss, and the disease progresses without remission for 15 to 25 years. It affects 30,000 people in the US plus Canada, and there are at least 150,000 Americans that are at risk to develop the disease. The therapeutic approaches include the only FDA-approved treatment, which is tetrabenazine, and it affects symptomatically only the chorea. The quest for finding treatments include targeting the RNA of the mutant Huntingtin, and among other approaches are the intrastriatal transplantation of stem cells secreting BDNF. The BDNF, or neurotrophin, is a secreted polypeptide of 119 amino acids, which is binding to the TRKB receptor. It is expressed in astrocytes, neurons, Schwann cells, fibroblasts, platelets, and smooth muscle cells. Upon the binding of the mature BDNF to the tropomyosin kinase B receptor, there are pathways activated that include phospholipase C, protein PI3 kinase through RAS, AKT, or actin, and the result is synaptic plasticity. Synaptic plasticity is affected, differentiation of neurons, growth and survival of neurons, and motility are all impacted by BDNF. Therefore, BDNF impacts neurodevelopmental and neuropsychiatric disorders as depression, anxiety, schizophrenia, ADHD, as well as neurodegeneration that includes Huntington's disease, Alzheimer's disease, ALS, mild traumatic brain injury. Therefore, modulating its level has great clinical potential. In regards to BDNF in Huntington's disease, we know that the BDNF levels are reduced in post-mortem striatal and cortical human HD, suggesting BDNF-reduced neurotrophic support in HD neurodegeneration. The reduced striatal BDNF levels in transgenic HD correlated with symptoms onset, and in addition, BDNF knockout mice present similar phenotypes as the HD patients. Restoring brain BDNF levels in HD mouse models showed ameliorated HD symptoms and increased neuronal survival in mice, and decreased striatal atrophy and reduced anxiety was noticed following intrastriatal mesenchymal stem cells, MSC BDNF, that were from both mice and human origin, and therefore there is great potential benefit for HD patients. Brain BDNF repletion in its potential use require quantitation of BDNF in cerebral spinal fluid as a translational biomarker. However, BDNF levels in CSF are below the level of limit of quantitation in most sensitive commercially available ELISA. We aimed to develop a very sensitive assay that will be able to quantify the CSF BDNF, and for this purpose we chose the SIMOA platform. We worked, as the presenters before, with the Accelerator lab at Quanterix led by Dave Hanlon, and I particularly work with Ming Wei and Nate Estoken. For this purpose, we used clinical samples that included plasma and CSF from non-HD controls from commercial sources, and we were extremely lucky to be part of the pre-cell study, which collects concurrently blood and CSF from subjects that are of early stage HD. This study is an observational longitudinal study, and its aim was to characterize rate of progression and looking at clinical and neuroimaging and laboratory biomarkers. And I am part of the Hirsch group at MGH that studied the biofluids biomarkers. The study undergo for 24 months, and blood and lumbar puncture CSF was obtained at 6 months interval. The study aimed to eventually enroll people that progress to the study and reach a certain level in the disease to be enrolled into a intrastriatal delivery MSC BDNF. Also, bioethics considerations were followed in this study. The enrollment included 32 subjects, 29 of which remained to continue the study for 12 to 24 months. 66 of these subjects were male. Basic characteristics of the subjects cohort included a broad age between 23 to 74, and below are the medians of the group. The CAG repeats were between 38 and 59, with a median of 42, and the total functional capacity, an indicator in disease progression, was between 9 and 13, with a median of 11. Please note the normal is 13. We analyzed first the plasma BDNF of the subjects by ELISA, and you can see that the subjects' plasma BDNF levels all across the visits within 24 months were all below the control levels in a significant manner. If we look at the profiles and the estimated trajectory of the plasma BDNF over time, we can see that in spite of an increase, this increase was not significant. In addition, there were no significant plasma BDNF associations with gender, age, or other significantly changing covariates, including CAG-N, TFC, burden of progression, total motor score, neurocognitive and assessments and imaging markers. We then started to develop the assay at Quanterix, led by, in Dave's group, by Ming Wei, and designated pipette. And we developed an ultra-sensitive SIMOA CSF BDNF assay. I need to mention that both plasma and CSF were platelets poor, as platelets may contain BDNF as well. The assay parameters listed here are the result of an optimization study for antibody pairs, concentrations, buffers, etc. So this is a summary of the optimization process. And the data presented include either A, B values, or BDNF concentrations. The standard curve generated reached our goal. As you can see, the sensitivity level was of 100 femtogram per ml. And to note, the most sensitive, at least published results, are for 30 picogram per ml. So our main goal was achieved. We then validated the assay, which is extremely important when the next goal is to analyze clinical samples. And some of the parameters of this validation include the dilutional linearity in samples that contain high CSF concentration. You can see that the linearity was not ideal. Probably part of the reason was matrix effects from some of the samples. However, the linearity was greatly and improved when we looked in spiked recombinant BDNF in CSF samples with low BDNF concentration done in 16 patients. So you can see the great range and average of this linearity. The spike and recovery of samples, again, with low background BDNF concentration, with a range of 0 to 20 picogram, resulted in great spike and recovery. The precision was undertaken on using calibrators and was done in 4 runs with 2 operators, resulting in great precision. This all with the lower, where 9 was the maximum CV. The assay had great intra-assay variability. Again, was tested with 3 to 5 replicates per 12 samples each. There were 4 runs and 2 operators. The intra-variability was lower than 9.4. And the inter-assay variability, the same parameters, resulted in a variability lower than 20%, which is a acceptable limit for the assays. An additional important factor, we noticed that there is a great correlation between samples obtained concurrently at 6 months interval. As you can see, there was a great correlation between visit 1 and visit 2. This is a time at which clinically you do not expect dramatic changes. So this represents both biological and technical great repeatability. We looked then and by the CMOS CSF BDNF assay comparing the CSF samples from all the 4 visits with control CSF, and we noticed an increase, at least at visit 1, that was trending to significance, levels being higher in HD compared to control. And this was, again, only at visit 1, 6 months from the initiation. We can, based on these results, we can conclude that 82% of the controls were quantitatable, and 66 of the early HD pre-cell subjects. This is very new in the CSF BDNF area. When we looked at the estimated trajectory of the CSF BDNF, we saw a minor increase with time, but this was not significant. Looking at the clinical covariates, we found that the CSF BDNF was not significantly associated with gender. So the CSF BDNF was not correlated to gender or to TFC, burden of progression, total motor score, neurocognitive assessment, or imaging markers, and was also not associated with the plasma CSF, with the plasma BDNF. The only association was found trending for CSF positively trending at 6 months only with CAGN, and inverse trend correlation with age. In conclusion, we developed a new CMOS CSF BDNF assay, which has an LLOQ of 100 femtogram per ml, This assay represents a more than 300-fold increase above commercial ELISAs. And after validation, based on the parameters I've shown, this is suitable to use as a quantitative assay. We then used this assay to analyze the HD subjects, and we found, as mentioned before, that 66 of the early HD subjects can be quantitated. The CSF BDNF in HD trended to have increased levels at the 6 months point compared to control, and this was in contrast with the finding in plasma BDNF. Also, it trended positively with CAG-N and inversely correlated with age. We showed that CSF and plasma BDNF did not correlate did not change significantly longitudinally, and they did not correlate with other clinical covariates. In summary, also, we did not quantify CSF BDNF in all subjects. Using this SIMWA assay, we will now be able to use CSF BDNF as a translational biomarker and potentially measure the therapies altering BDNF in the brain for different repletion strategies that one can use. Thank you. And the next slide, I'm sorry, the most important is our collaborators, which include the UC Davis team led by Dr. Vicky Willock and the Accelerator Lab at Quanterix. And of course, our gratitude to the subject and their families. Thank you.
So maybe I was confused, which I normally am. It's just my state of mind, so don't take it personally here. The plasma and the CSF data, there seem to be higher concentration of BDNF in plasma than there is in CSF. So what you presented for plasma, was this measured on the Samoa as well, or was?
No, the plasma was measured on ELISA. The range levels are in picogram per ml. The concentration are much higher in plasma than in CSF. Okay. But they were lower in early Huntington disease than in control.
Okay, but so basically what you saw in CSF for BDNF with the Samoa assay now was a mirror image of what you presented in plasma?
No, the CSF...
See, I'm confused.
The CSF BDNF levels were slightly higher than the controls.
Okay.
And they did not correlate to the finding in plasma. The similar results have been obtained in Alzheimer's disease. Also, they used an assay that was much less sensitive than the SIMWA, and they were able, therefore, to detect in much less patients, percentage-wise.
I guess my question was, were the same antibodies employed in the Samoa assay which was used for the plasma assay?
The plasma assay is a commercial assay. We tried to... We think we use the same antibody. They are proprietarily.
So you basically don't know?
One of them is the same antibody. The other is probably the same as it's used in the plasma.
And the fact that we don't see a correlation maybe is not so surprising. Isn't that one way of...
As I mentioned to you, they've had similar findings in AD, where the plasma levels...
Doesn't mean anything to me if it's a I mean, this is maybe a discussion over coffee. Danielle had a question and then...
It was the same. I was curious if they were using the same antibodies that you had in the platforms. It was just, you already asked it. It was the antibody question.
Okay. So if there are no more questions from Mariam...
One question may be answering. It may be related to the fact that the BDNF level is slightly higher in CSF than controls, may be related to the leakage from BBB. That's one potential reason.
But I mean, also BDNF, doesn't it come in a pro form and in a full form, or do I misremember my neurochemistry now? It could well be. So, you know, there are finite minute differences to these assays we've learned in drug development, or I've learned over the last 25 years. So, you know, I think this deserves potentially further exploration, I guess. Maybe that's one way of saying it.
We are detecting most likely mature form of BDNF. The pro-BDNF binds to a lower affinity receptor, and it's cleaved after activation.
Yep.
So we are most likely measuring mature form.